On the field, acute care and emergency procedures. When injuries occur, they require prompt care, particularly if they are life-threatening emergencies. Emergencies are unexpected occurrences that require immediate attention. Time is a factor, and the first hour is considered the golden hour. We need to care for our patients within this first hour to have an optimal return on our care. Mistakes in the initial injury management can prolong the length of time required for rehabilitation and recovery or cause life-threatening situations to arise. Some of the allied healthcare professions you all are interested in require more advanced knowledge of immediate and emergency care. We will look at an overview of pertinent information related to immediate and emergency care for this course. Emergency Action Plan. Emergency action plans are a set of instructions to be executed in the case of an emergency. Every sport venue, hospital, public location, and allied healthcare facility you have ever been in should have an emergency action plan. You just may not have seen it. Within the emergency action plan, the primary concern is to maintain cardiovascular and central nervous system functioning. Within the emergency action plan, the primary concern is to maintain cardiovascular and central nervous system functioning. The key to emergency aid is the initial evaluation of the injured patient. Members of a sports medicine team specifically must at all times act reasonably and prudent to respond to the emergency. There should be pre-arranged plans that can be implemented on a moment's notice. Separate emergency action plans are developed for each facility, and they should outline personnel and the roles of the individual and identify the necessary equipment. It is important these emergency action plans identify that the person calling 911 or other emergency care should relay the following concerning the condition of the individual that's injured: the type of emergency, suspected injury, present condition of the patient, the current assistance that is being provided, the location of the phone being used, particularly if this is a cell phone, the location of the emergency, including an actual physical address, knowing the address of your location, and any building limitations. For example, are there specific doors or gates that emergency personnel should enter through? Also, parent notification. When a patient is a minor, under the age of 18, try to obtain consent from the parent prior to emergency treatment. If we have consent before an emergency occurs, this removes one barrier to providing care. In most organized sports, this is generally provided at the start of athletic or activity participation. The principles of on-the-field injury assessment. Appropriate acute care cannot be provided without a systemic assessment occurring on the playing field first. On-the-field assessment determines the nature of the injury, provides information regarding the direction of the treatment, and is divided into primary and secondary surveys, which we'll discuss. A primary survey is performed initially to establish the presence of life-threatening conditions. Airway, breathing, circulation, shock, and severe bleeding should be assessed and ruled out as non-life-threatening. The primary survey is used to correct life-threatening conditions. Life-threatening conditions take precedence over all other injuries. Some examples of life-threatening conditions could be injuries requiring cardiopulmonary resuscitation, profuse bleeding, and even shock. The level of the consciousness of the patients may also be assessed. The secondary survey occurs once life-threatening conditions are ruled out. This provides specific information about the injury. We assess the patient's vital signs and perform a more detailed evaluation of conditions that do not pose life-threatening consequences. It is important to remember that the secondary survey is still important. Many of these conditions or injuries, if not treated correctly, may become life-threatening conditions if they're not cared for in a timely fashion. Establishing responsiveness. If a patient is unconscious and breathing, Nothing should be done until consciousness resumes. Monitor the patient and activate emergency action plans. To establish responsiveness, first check for life-threatening conditions and determine if the environment is safe to enter. Ask the athlete, "Are you okay?" and gently tap them. If there is no response, emergency medical services should be activated and the positioning of the body should be noted and adjusted in the event that CPR or cardiopulmonary resuscitation is necessary. A patient that is breathing in a prone or side-lying position should be placed in what's called a recovery position. If our patient is in a position other than supine, meaning that they're laying on their belly or on their side, then the patient should be carefully log rolled as a unit to limit cervical motion so that they are laying on their back. This is important in the event that the patient stops breathing and we have to perform CPR. Different types of shock. Shock generally occurs with severe bleeding, fractures, or internal injuries. Shock can be the result of a decrease in blood available in the circulatory system. Extreme fatigue, dehydration, exposure to heat or cold, and illness could also predispose a patient to shock. There are several different types of shock. Hypovolemic shock occurs when there is a decrease in blood volume, resulting in poor oxygen transport. Respiratory shock, the lungs are unable to supply enough oxygen to circulate the blood. This potentially could be the result of a pneumothorax. This is a lung injury which we'll discuss later in the course. Neurogenic shock is caused by a general vessel dilation, which does not allow the typical 6 liters of blood to fill the system, decreasing oxygen transport in the body. Cardiogenic shock is the inability of the heart to pump enough blood. Psychogenic shock is fainting caused by a temporary dilation of vessels, reducing blood flow to the brain. Septic shock is the result of a bacterial infection where toxins cause smaller vessels to dilate. Anaphylactic shock is typically the result of a severe allergic reaction. Metabolic shock occurs when illness goes untreated, such as diabetes, or when extensive fluid loss occurs. The most common signs and symptoms of shock include moist, pale, cold, clammy skin, a weak or rapid pulse, increased and shallow respiration, and decreased blood pressure. Urinary retention and fecal incontinence, irritability, or excitement and potential thirst are also signs and symptoms that you may see. This is a table with different signs and symptoms of shock related to the different causes of shock. You do not have to memorize this table, but understand that the different causes of shock are going to result in different signs and symptoms. The management of shock. To manage shock, maintain a core body temperature. Elevate the individual's feet and legs 8 to 12 inches above the heart, if possible. However, if there is a fracture to the lower extremity, please do not move the lower extremity. It is important to understand that the patient's position may need to be modified due to their injuries. Keep the patient calm, as psychological factors could lead to or compound a reaction to life-threatening conditions. Limit onlookers or spectators. Crowd control is important. Reassess the patient and do not give anything by mouth until instructed by a physician. The secondary survey. Once a patient is deemed stable, a secondary survey can begin. This is where we assess the patient's vital signs. Pulse is a direct extension of the heart function. Normal pulse for an adult is 60 to 80 beats per minute. However, an athlete may be slightly lower. The pulse of a child is generally a little bit faster, running from 80 to 100 beats per minute on average. A rapid and weak pulse could indicate shock, bleeding, diabetic coma, or heat exhaustion. A rapid and strong pulse could indicate heat stroke or fright. A strong and slow pulse could indicate a skull fracture or stroke. And no pulse should indicate that cardiac arrest has occurred or death. In the case that the patient has no pulse, we should initiate CPR. The state of consciousness. How do we assess consciousness? The AVPU scale assesses the following: alertness, verbal, pain, and unresponsiveness. The ACDU is a 4-point scale that has been suggested by other medical professionals and assesses alert, confused, drowsy, and unresponsiveness of patients. The musculoskeletal assessment. With musculoskeletal assessments, you must use a logical progression to adequately evaluate the extent of trauma. Knowledge of the mechanisms of injury and major signs and symptoms are critical. Once the mechanism has been determined, specific information can be gathered concerning the affected area. When taking a history from a patient, have them describe the events of the injury and those leading up to it. This can help us to determine past history, previous injuries, and the treatments that were used. Determine if any sounds, grating, crepitus, which is snapping or cracking, or rubbing that may have accompanied the injury. With the visual inspection, inspect both the injured and the uninjured area. Look for changes between the two. Look for gross deformity, swelling, and skin discoloration. When palpating or touching an injured area, you should work to identify the extent of tenderness and what structures are affected. You may also assess if there are other deformities that were not apparent through our visual inspection. When palpating, start away from the site of injury and work towards the injured area. If we go to the point of injury, our patients are not going to let us continue for very long. Once you have completed this assessment, you will need to make immediate treatment decisions and plans for care. Immediate treatment of injuries and conditions. The immediate treatment often sets out to limit swelling and the extent of hemorrhaging. If controlled initially, rehabilitation time may be greatly reduced. The immediate treatment for most injuries utilizes the RICE method: rest, ice, compression, and elevation. With rest, the stresses and strains may be removed following injury as healing begins immediately. Days of rest differ according to the extent of injury and the type of tissue injured. Ice is typically used in the initial treatment of acute injuries. It is used for sprains, strains, contusions, and inflammatory conditions. Ice should be applied initially for 20 minutes. Getting ice on an acute injury in the first 10 minutes is essential to care. Compression decreases the space allowed for swelling to accumulate. A number of means of compression can be utilized. Compression should be maintained for at least 72 hours and may initially be uncomfortable due to the pressure buildup. Elevation reduces internal bleeding due to forces of gravity. This can help us to prevent pooling of blood and aids in the drainage. The greater the elevation, the more effective the reduction of swelling is for the patient. Emergency splinting. You should always splint a suspected fracture before moving the patient. Not all allied health professions will be expected to be able to perform emergency splinting, but it is an important step to understand. Without proper immobilization, increased damage and hemorrhage can occur, leading to potential death if handled improperly. Emergency splinting is a fairly simple process utilizing different techniques, including a rapid form vacuum splint, an air splint, a SAM splint, or a half ring splint. There are several other commercial products that can be utilized as well. A rapid form vacuum splint has styrofoam chips that are sealed within an airtight sleeve. We can mold the splint to the patient with Velcro straps. Air is then removed to make the splint rigid, supporting our patient. An air splint is a clear plastic splint that is inflated with air around the body part. This can be used for splinting, but it does require some practice. We do not use this if this could alter the fracture deformity. This provides moderate pressure and can be x-rayed through. A SAM splint is a thin sheet of pliable aluminum that's covered with padding. SAM splints can be utilized for less traumatic fractures and emergencies. The nice part is you can mold it to different body parts. And finally, a half ring splint is used for femoral fractures. This requires extensive practice. Open fractures must be dressed appropriately to avoid contamination and should be sent to an emergency department as soon as possible. The proper fitting and usage of crutches and canes. Crutch or cane fitting may or may not be a responsibility of your career. Knowing if a patient's crutches or cane is fit properly may be, though. When lower extremity ambulation or walking is not recommended or contraindicated, a crutch or a cane may be required. Ambulation is walking, partial or full weight bearing. Faulty mechanisms or improper fitting can result in additional injury and potential falls. When fitting a patient with crutches, the patient should stand with good posture. They should be in flat-soled shoes, such as tennis shoes. Flip-flops and other shoes that are floppy on the feet are not recommended. Crutches should be placed 6 inches from the outer margin of the shoe and 2 inches in front of the shoe. The crutch base should fall 1 inch below the anterior fold of the axilla or the armpit. The hand braces should be positioned to place the elbow at 30 degrees of flexion. For canes, the cane measurement should be taken from the height of the greater trochanter. Cane or crutch ambulation. With the tripod gait, the patient should swing through without the injured limb making contact with the ground. The tripod gait is slightly different than the 4-point crutch gait. The 4-point crutch gait, the foot and the crutches on the same side move forward simultaneously with weight bearing. This allows a patient to regain the functions of walking and to practice their walking skills without full weight bearing on an injured extremity. In the cane, a tripod gait is used on level surfaces and may be modified with stair climbing. Crutch walking follows a logical progression from no weight bearing to touchdown weight bearing to partial weight bearing to full weight bearing. When using one cane or a crutch, the support should be held on the unaffected side.